So I want to thank everybody for attending this little breakout session. I hope we can make it fun. I know everybody's been sitting, listening to talks and so on. So we're going to try something a little more interactive with this session. So bear with me. We're going to talk about screening for and managing some of the comorbidities in older adults with HIV. And I do want to make this kind of interactive as we go along. So you guys are all unmuted. And if everybody behaves, we'll keep it that way. So no arguments about whether to use aspirin or whatever. So let's get started. We have a couple of little questions to begin. And Dennis, if you want to queue up the first polling question. So what we're after here is just to get a sense about how many older people you are seeing in your practice. And I've sort of given you some general percentages, but you know, let's just see. So this first question is having patients at least 50 years old. And all right, so you know, it looks pretty interesting. Can everybody see the, Dennis, can people see the poll results or just me?
Everyone sees them.
Okay, cool. Just trying to get used to this platform. All right, so it appears that a lot of people have large numbers of people who are over 50 years old. 41 to 60% of almost half. So I think that's really interesting. Now I'm interested to see in our second poll question, what about patients who are at least 65 years old? Expecting smaller numbers here, but you know, I'm just interested. Some of us who started back at the very beginning of the epidemic, those of us who are older than dirt, have a lot of patients who have aged with us along the way. All right, so interesting that most people seem to have between 1% and 20% of people who are in this older category. All right, cool. So I thought that we would start by maybe getting you guys moving a little bit. Now, you know, you're in your own Zoom room and you can turn off your video if you don't want anybody to see, but I thought it would be fun to do a little bit of frailty work. Let's first do a poll question. So what I'm interested in knowing is, are you screening for frailty in your patients who are 50 years old or older? And you have some answers here. No, my visits are too busy already. No, I really haven't even thought about it. Sometimes if the patient seems frail, and always. So what are you doing? Okay, interesting. So we have some people who are being uber honest and saying, yeah, my visits are too busy. I just can't do another single thing. A lot of people who just really haven't been thinking about it. So that's my job today. And the largest number saying sometimes if the patient seems frail. All right, cool. So one more question here on frailty. If you are screening, which one of the tools do you use? And I've listed the 3 tools that I talked about this morning, which are kind of the common ones. I'm aware that other people might use other tools like Edmondson and so on. And so I'm really interested to see who is using what. Okay. Kind of all over the map with something else being a popular answer. Okay, cool. And about 30% are using the SPPB. So interesting. Okay. Well then, anybody want to share what's something else you might be using?
We do the time to get up and go pretty often.
Okay. Oh, giving away my slides. All right. That's pretty easy. That's an easy one. All right, so one reason that we need to be thinking more about how to measure frailty, aside from the fact that it seems like a really good thing to do in patients who are getting older, is that Medicare is beginning to look at this. And there actually was an interesting study just published in the Annals of Internal Medicine that that basically said if you used a frailty index, it improved fairness in physician reimbursement. So positing that physicians or providers should be reimbursed more for patients who are more frail and require more attention. So I thought that was really interesting. Who knows what will come of it, but you know, hot off the press in April. Okay, so I thought we would kind of go through the SPPB today and let you guys measure your own frailty. I think some of you are not going to be at risk for frailty, but others might be. But really the point is to show you that this is really a doable thing. It's a simple thing to do. And so what I'm going to ask you to do is to run through these exercises with me and to score yourself. And then we're going to see how everybody does. And so we're going to do the balance test first. There are 3 balance tests. And I'm going to be the timekeeper for this one, although I'm going to ask you to be the timekeeper for a couple of other things. So in your practice, what you are going to do is to tell the patient that we're going to do some balance tests. If they feel comfortable with it, if they don't feel that they can do it, then that gives you a score right there. But if they feel that they can attempt this, you want to say to them, I want you to try to stand with your feet together side by side for about 10 seconds. So I'm going to ask everybody to stand up and stand feet together, side by side. All right, and I am going to give you your timing. All right, ready, go. And you're going to stand there for 10 seconds. You can use your arms to balance if you want to. You can move your body, you can bend your knees, but don't move your feet. Okay, 10 seconds. Very good. Now, everybody give yourself a score. If you held it for 10 seconds, you give yourself a point. If you didn't, no points. And if you couldn't attempt it, then also no points. Okay, now we're going to go a little bit harder. The semi-tandem stand. So if you'll stand up again. So I want you to stand with the side of the heel of one foot beside the big toe of your other foot. Okay, got that? So the heel of one foot beside the big toe of your other foot. And you can use either foot, whichever is comfortable. All right, we're going to do this for 10 seconds. Ready, go. All right, awesome. 5 seconds. Keep going, keep going. All right, 10 seconds. That was easy. All right, give yourself a score. Did you get a point? If you didn't hold it, you don't get a point. And if you couldn't attempt it, then no points for that either. All right, so these get progressively harder. This time we're going to do a tandem stand. And so this time stand up again. We want you to stand with the heel of one foot just in front of the toes of the other foot, sort of like you're walking on a tightrope, and either foot can be in front, and we're going to hold that for 10 seconds. Okay, ready, set, go. Right, almost there. Hang in there. All right. Okay, end. So here's the deal. You're going to have to do a little guessing here. If you held it for 10 seconds, this one gets a big reward. You get 2 points. If you held it for 3 to 9.99 seconds, then you get 1 point. If you gave out at less than 3 seconds, then unfortunately you don't get a point. And also if you couldn't attempt it, you didn't get a point. So I suspect most people did pretty well, but you know, this is where you begin to break down a few gradations in terms of ability. Okay, next, I want you to look around you and focus on something that is about 3 or 4 meters away. We'll say 3 meters away at this point. Now, if you have a watch or a phone, then I want you to get set to measure your own time, okay? So what you're gonna do is to walk this course twice, and we're gonna get you to use the fastest time, all right? So stand up and face your destination, whatever you have chosen. And when I say go, I want you to walk to that destination and then record your time. Okay, so this is loosey-goosey because we didn't really measure it, and in real life we'd really measure it, but you know, it's a breakout session. So, okay, ready, set, go. Okay, so if you're still walking, then I don't think you get very many points. So now here is the way you score. So make a note of how long it took you to do your 3 meter walk. If you did it fast, less than 3.6 seconds, you get 4 points. And then you grade yourself all the way down. Okay, so let's do it one more time. And let's give yourself a chance to improve. Ready, set, go. Okay, I see people coming back. Very good. So record your time. All right, now this is the last test, and this is the repeated chair stand test. So you're going to stand 5 times from a seated position with your arms folded across your chest, okay? And you're gonna do this as quickly as you can, but you are gonna time yourself, okay? Now this is a little harder than it seems actually, and some people who are, you know, relatively younger or whatever actually don't score all the 4 points. So give yourself, get comfortable in your chair. And when I say go, we'll go and time yourself, all right? So arms across your chest like this. You can't use your arms to stand up. Okay, 3, 2, 1, go. All right, 5 times. Up and down and up and down, all right. Some of you guys look like you're at the gym. All right, cool. All right, so score your time. And now, basically, we're going to tally up your whole score. And if you scored 10 to 12 points, you're in pretty good shape. If you scored less than 10 points, then this is where we begin to worry about frailty, and less than a score of 10 predicts high risk of mortality, but it also predicts hospitalization. It predicts other things like inability to do activities of daily living, inability to walk a longer distance like a half mile. So, you know, really my point in doing this today was not so much to see how you score, but if you have any insights from your own scoring, that's cool. It's really to point out that it really doesn't take too much time to do this. And actually in an exam room, you can do it all within about 5 minutes. And this is not the kind of thing that you need to do every time, but I think periodically it's something that we should consider doing, this or another, your favorite frailty test, because what happens is that people minimize, particularly older people, often minimize their physical shortcomings, and they tell you they're doing fine, they're good. But when you actually ask them to do some tests, sometimes it begins to tease out the people who actually are a little more frail than they appear when they're just walking into your office. So I hope that was kind of fun for people. It's just a little different way to look at things. So I just wanted to give people a second to give some feedback about frailty. Is this something that you feel like really is too burdensome to do? Do you feel like it's worthwhile? Are there people who have, gotten benefit out of doing these frailty scores? Anybody want to share an experience?
Hi, this is Diane. I think that in our clinic we do have a lot of frail patients, and I think this would be great. We do not do it now. However, we have an excellent ancillary staff that could probably do this for physicians. We have a nurse educator that does basically smoking cessation, does some lipid counseling, but I think this would be a great spot to integrate into her activities of the day.
So that you bring up a great point that, for those of us working in a clinic environment, we have teams, and it doesn't have to be the care provider who is actually doing this. So others on the team could do it. So that's a really good point. And, I would also say that the point of this is not to say, oh, you're at high risk of death, but we can intervene. This means it's time to intervene and do other things to try to help people build strength and to avoid those bad outcomes.
Presumably.
Yeah, go ahead.
I just want to make sure that you're going to talk about the interventions because, screening is all well and good, but we're not neurologists. We want to actually be able to do something about it.
Yeah, so, there are not a lot of data for, the single most valuable way to improve frailty, but it's recommended that you really tailor programs to the individuals. And for most people who have physical frailty that you would pick up on something like this, almost everybody can get some benefit by improving exercise. And, whether that is doing resistance exercise, whether it's doing chair exercises, or whatever. Now, some people can benefit from physical therapy. You can actually send people to physical therapy with a diagnosis of sarcopenia and get a physical therapist to work with them. So, I think the point of this is to help the patient understand their own frailty and to work with them to see how you can actually help them improve their strength. Improving their core body strength is important. Being able to stand up from a chair is a big deal. And I think when you lose that ability, you have lost a lot. So working on that with patients who didn't do well on that is an important thing to do. And a physical therapist can be very helpful if that is an option. But there are other things involved in frailty, and particularly if you look at some of the questionnaires like the Frailty Index and so on, they are looking at psychological issues. And, we shouldn't underestimate how many of these patients may have some depression, particularly right now with COVID involved. And so I think it's really important to ask some probing questions about mood and, people who don't really have any energy to do anything are likely not getting physical activity. So I think honing in on depression screening is also a really important intervention for this population. All right, so let's move on. I prepared just a little material for this, and then we'll get kind of freewheeling and see if there are other questions that you guys want to cover. One of the things that people ask a lot is, what's the target for LDL? So what is my LDL target when I am treating patients with statins? So let's start with a polling question. So what is your target for a person living with HIV who has a 10-year risk of greater than or equal to 7.5%? The answers are 130 milligrams per deciliter if there aren't any risk factors, 100 milligrams per deciliter, 70 milligrams per deciliter, and then, oh, this is a trick question. There really isn't any target. So what do you guys think? Okay, so we have about half who are saying 100 milligrams per deciliter. And then, 20% here, 20% there. Very few people think 130. All right, cool. So let's see what the American Heart Association says. In their 2018 guidelines for the management of cholesterol, they basically say that there's no target, that evidence does not support treating to a specific LDL or non-HDL-C target. So if you said this is a trick question and there isn't any target, then I think you get credit for that. On the other hand, actually, when you look at the guidelines, it seems to me that they identify quite a few targets. We'll go through some of those targets, but I just want to catch everybody up on the classification of the statin drugs. So when they recommend low or moderate or high intensity statins, everybody has a good idea of what they are really talking about. So atorvastatin is never a low intensity statin. But that would be a low dose of pitavastatin or pravastatin at a moderate dose. And then some of the others that we don't use much, lovastatin, simvastatin, and HIV because of drug interactions. But then almost all of the drugs listed here have a dosage at which they are considered moderate intensity statins. But the moderate intensity statins are expected to reduce LDL by 30 to 50%, somewhere in there. And then the high intensity statins, really there are only two, atorvastatin and rosuvastatin at the higher doses, at the two higher doses. And there we're looking for a 50% reduction. So here are some of the ways that they say there is no target, and then they put targets in the guidelines. So first of all, for people who have clonical heart disease or atherosclerotic disease, you want to use a high intensity statin or a maximally tolerated statin with a goal of reducing by 8%, so 50%. For people who are very high risk, then here comes a target. They want the threshold of 70 milligrams per deciliter to sort of be the threshold that you want to go below. So it's not exactly a target, but you want to go below 70 milligrams per deciliter. And you do that by adding a non-statin drug if you haven't gotten there with the statin that you chose. And then for severe primary hypercholesterolemia, they choose a threshold of 100 milligrams per deciliter to add additional drugs. So you add one drug first, and if you don't get down below 100, then you're going to go for the big expensive gun of PCSK5 inhibitors. So, and it goes on with a lot of targets here. If the patient has diabetes, then you want them below 70, and you could start with a moderate intensity statin if you think that will work for them. But for people who have no diabetes and who have an LDL greater than 70, then it really is going to depend on your risk score. We've already talked about how these risk scores are not perfect for people living with HIV, but these guidelines are basing statin therapy on the risk score. So, basically you want to get people below 70 if they have a risk of 7.5% or more. And then, the high intensity statins are the drugs of choice if the risk goes up to 20% or so. And even at lower risks, if people have risk enhancing factors, you can consider starting a statin. And, I think this is where, the art of medicine comes in, because we don't have really clear goals about how HIV acts as a risk enhancing factor. I went over some of the issues this morning that increase risk, like uncontrolled virus, like low CD4 and so on. But, you could take a person who actually has lower risk, but fits into these categories and consider a treatment for them. But the other thing that is recommended in these areas where you're really not sure whether to use a statin or not is to get a coronary artery calcium score. And I think this also is interesting in the setting of HIV, because we know that people with HIV also have non-calcified plaque in addition to calcified plaque. So the coronary artery calcium score doesn't really fully characterize the risk. And so if it's negative, or meaning 0 or so on, it may be low risk. You may wait for a statin, but you actually, if you have other things that worry you about this person, then you could get a CT angiogram, which is really a better way to look at non-calcified plaque. On the other hand, if you get a coronary artery calcium score and that score is measurable, particularly if it's high, then they've got some coronary plaque and you want to go ahead and treat them. So I wanted to point out just a couple of little things. This is an interesting thing, and it is truly hot off the press, August 5th from JAMA Cardiology. I don't know where this is going, so don't go ordering high sensitivity troponin 1 on every patient, but just keep it in the back of your head that this is going to be evaluated as a biomarker that could help predict risk. So we all know that a high troponin is a bad thing, but it appears several studies have shown that lower levels of troponin 1 actually can confer information about sort of intermediate risk. And so this study, it was a sub-study of a very large cardiovascular trial called Pegasus-TIMI, and it looked at the predictive value of high sensitivity troponin 1. And it turns out that if the level is undetectable, like less than 2 nanograms per liter, the event rate for those people was actually low. Even if they were categorized as high risk, they would be recategorized as a lower risk based on this outcome, this biomarker. And at the same time, people who were in the low risk bucket otherwise who had a high level, which was greater than 6 nanograms per liter, actually had a high event rate that was comparable to those who were initially classified as high risk. So the point of this study is that almost 12% of patients were actually reclassified from low to high or high to low by the use of this marker, looking at actual clinical outcomes from the study. So I think that's interesting. You know, I think we have to take a look and see how this gets acted on. This particular research group was lobbying the American Heart Association, the ACC, to include this as a marker in their risk calculator. But I don't know if we're there yet. But I just thought this was a very interesting point with a fairly large study.
Dr. Thompson, there's a question in the chat room. Just want to make sure you see that. It's using HIV as diagnosis for CAC. What is your experience with reimbursement?
Okay, first of all, I am not seeing my chat room. So not sure what happened with that. So I might have to have some help.
Sure.
With the chat room, because it's not showing up for me.
Sure. We'll field you those questions.
Oh, okay, wait a minute. There we go. There we go. It was hiding. So reimbursement, I mean, you know, it's an interesting question. Once upon a time, it was really hard to get reimbursement for the CAC scan. It turns out that recently, my experience in the last year or so has been that I get less pushback about that, and we're getting more coverage for it. So, you know, honestly, I never know what insurance is going to reimburse for anymore, and it seems to change by the day. I always tell my patients, this is a test that your insurance may not pay for. So let's figure out how much it's going to cost you. Here are the benefits of getting the test. You know, you can decide if this is something that you want to do, because I honestly can't tell. But I just anecdotally, I have had better results in the last year or two in terms of getting insurance to pay for this without having to write long letters for anything.
Melanie, this is Ernesto Madrid. How are you using the guidelines to manage hyperlipidemia in patients who are younger than 40 that were diagnosed in their 20s and they've been using protease inhibitors or efavirenz for quite some time, and now they have hyperlipidemia? Of course, we cannot measure the risk factors because they are younger than 40. So how are you managing those patients?
Well, you know, I think as we have many of these folks who have been on long-term antiretroviral therapy, and, you know, of course, I live in the South, so everybody has more hyperlipidemia and hypertension and so on than you may see in other parts of the country. But even if a person is younger and they have multiple risk factors, then if you're unsure, one of the things I think you can do is to get a coronary artery calcium scan. I think it can be really helpful in that situation. But I am, you know, if somebody's lipids are not well controlled, I use a lot of statins. I try to get lifestyle change traction. It's hard, but, you know, some people are really very good about doing it. But for somebody who has, even if they're younger, maybe especially if they're younger, and they don't quite meet criteria, I am likely to treat them if the rest of their profile indicates that they've been pretty high risk.
Okay, thank you.
Can you talk about the thought that perhaps TDF may improve cholesterol profile versus TAF, and whether that's clinically significant or something that we should be considering?
So if you ask Gilead, it is not clinically significant. And that is because in all the studies of TAF versus TDF, TAF, when you change from TDF to TAF, you see an increase in cholesterol, but it's an increase in LDL as well as HDL. So the ratio doesn't really change. But it is true that TDF does lower cholesterol. So we mainly see the increases in cholesterol with TAF when people are changed. We see the most dramatic change when people are moving from TDF to TAF. But TDF itself does indeed lower lipids. And so it is something to take into account if you are looking at someone's antiretroviral therapy. They have some lipid problems, and they don't have renal issues, they don't have bone density concerns, then, TDF is a good drug. It actually, we used it a really long time. Now, it does have side effects more than TAF, but I think particularly with new data that we're seeing with the weight gain associated with TAF, particularly in association with dolutegravir, it's going to be increasingly important to look at these sort of issues. So would I change somebody's TAF to TDF if they had an elevated cholesterol? I might, for a number of reasons, if they seem that they could tolerate TDF. Another reason is that Truvada is going to be generic. TDF FTC is going to be generic in the US, at least it's supposed to be sometime this year. And I think we really do also have to keep our eye on the cost of drugs. So, just as with PrEP, many people on PrEP do just fine with TDF FTC rather than the TAF FTC formulation. So I still use TDF FTC. But that's a really great question. So thanks for bringing that up.
Thanks.
Other lipidish questions? All right, so.
I have a question.
Yeah.
Yes, in regards to assessment for risks for coronary disease, we all know it's a little bit difficult using the risk calculator recommended by AHA, and that we may, let's say a patient doesn't have an LDL greater than 190 or hasn't had a coronary event, but they're HIV positive, and how to put that then into the calculator or assess that risk, I know has been an ongoing debate. And at some point that level was said if they had an additional risk factor, then maybe we needed to start statin therapy at 5% instead of the 7.5%. How are you assessing their risk utilizing that calculator? I've heard other people maybe put an HIV patient in as a diabetic to completely assess that risk, or maybe lowering that threshold to 5%. I'm just curious on how or what your recommendations are in terms of assessing that risk.
Yeah, that's a great question, and I sure wish I had a good answer for you. It's an answer we need. We really need a good answer to this, but I think it certainly is a risk expander. You can play with the tools, and there are different studies that show HIV as a risk that may be comparable to diabetes or comparable to smoking or whatever. So I think you can potentially enter in one additional risk factor to one of the calculators, or you can just do the calculation and then just say, well, I really got a fudge factor here because HIV is a significant risk factor. And then keep in mind that not all HIV is equal, that people who have these low CD4 counts and so on are at higher risk. Now, looking at the DAD scale, So, you know, DAD is a huge study that looks at adverse events from antiretroviral therapy. And they have their own risk calculator. And you can play around with that too, because it does include things like antiretroviral therapy. Not all antiretroviral therapy, but, you know, abacavir and PI use and things like that. So, and CD4 count. And I have often used that in conjunction with the AHA-ACC calculator, just to see what kind of a range I get for risk. And even though it is said that DAD also underestimates, I think you sometimes see a pretty substantial difference when you put in the CD4 count, or, you know, and that does influence me in how I assess their risk. So that's not a great answer, but we need better answers.
No, absolutely. Thank you for sharing.
Yeah. All right, so there were some questions after the plenary about hemoglobin A1C. And there were several people who asked, well, if we can't use hemoglobin A1C for the diagnosis of diabetes, then what do we do? Please review the criteria for the diagnosis of diabetes. And so, first of all, I would just say, you know, this caveat only applies when that person is on antiretroviral therapy. So you may have a window with new patients, unless you are doing a rapid start in which you're actually getting them on drug at the first visit when they come to your clinic. And if you are, yay for you. But you know, if the patient is getting labs, or if the patient is coming back, then you know, this may be something that you would want to order before the patient starts antiretroviral therapy. Or if you're looking at the patient and they have a number of risk factors already, you may want to order this before you put them on antiretroviral therapy, just to kind of to get a sense of whether they are indeed diabetic by this measure. So it's the therapy that matters. But once somebody is on antiretroviral therapy, then you are back to old school. And old school is the fasting plasma glucose of at least 126, and you would want to repeat that. Or doing a glucose tolerance test, and so that's 75 grams of yucky oral glucose, and then measuring the plasma glucose 2 hours after. If it's greater than 200, then that is a diagnosis of diabetes. And then someone who has a random plasma glucose more than 200 and also has symptoms meets criteria for diagnosis of diabetes. So, you know, I think it's important to kind of go back to the basics and remember that plasma glucose does indeed diagnose diabetes for us much of the time. And then what about following hemoglobin A1C once somebody has been diagnosed with diabetes, or they come to you and are already diabetic and on treatment? You know, I think you always have to think about it with a grain of salt. As long as they are staying on the same antiretroviral therapy, then you may be able to follow hemoglobin A1C, because it does seem to vary according to different antiretroviral therapies. But, you know, if they're on an integrase inhibitor and some NNRTIs, and then you change them to a boosted PI, then, you know, it may be dicey. I wouldn't compare the hemoglobin A1C from one to the other. But, you know, I think for patients with diabetes, what they are going to be following also is their blood sugar. And so this is an important lesson for them to learn about following their blood sugar, fasting blood sugars, and so on. So, let's see, trying to look at questions up here. So there's some questions about aspirin. Oh boy, sorry.
Sorry, I just had a comment about the A1C because this is a really interesting concept because you know, traditionally with our clinic we've always just monitored with A1Cs, and I have a difficult time with patients coming in fasting because a lot of times we'll get a lipid panel and I can tell the triglycerides are high and that they got their labs at 1 o'clock in the afternoon and they really weren't fasting to get those labs. And so I'm curious how well, yeah, my first question is I'm curious how you are then assessing this fasting glucose. Is it just, you know, making sure patients are going into their labs fasting to be able to use then the plasma glucose criteria instead of using the A1C? And then question 2 is, I know earlier you implied certain antiretrovirals gave them a greater risk of altering this relationship between the A1C and the glucose, particularly tenofovir, if there were any other particular drugs that alter that relationship.
Well, not particularly tenofovir. So if I said that, I didn't mean to, but you know, it is one of the drugs, but other NRTIs, NNRTIs, PIs, you know, so I think basically you should assume that all of the antiretroviral combinations could have an effect on hemoglobin A1C, and there's no real fudge factor. It's not like tenofovir, you should correct by 0.3, and PIs you should correct, you know, add 0.3 for this or subtract 0.4 for that. You really can't do that. So I agree with you that fasting labs are a problem. And in fact, you know, for collecting lipids, we don't require fasting labs anymore. The guidelines don't require fasting labs, but then you get exactly what you pointed out, that there are high triglycerides, and that can interfere with measurement of LDL. You know, then you have to go back and say, okay, you know, maybe we do need you to come in fasting. So, you know, I'm not requiring people to come in for fasting labs in general, but if I see a red flag, that's when I try to work with the patient to come in for a fasting lab. And, you know, you have to work around their work schedule sometimes, and, you know, but I think if it is important, you know, you need to know somebody's LDL and their triglycerides are 700, and, you know, then you try to work with them to get them back in to do a fasting glucose. You know, on the other hand, if you do a hemoglobin A1C and it's, you know, 25, then I think you have a problem there.
Just to go for that, this seems like it would be pretty practice changing, actually, learning this. So, you know, I usually shy away from doing at-home monitoring if somebody's just on like 1 or 2, you know, glycemic agents. But I can see myself maybe trying to get glucometers into the hands of more of my patients that are living with HIV to try and get more at-home fastings, because otherwise, you know, I don't know. I don't know how I'm going to really monitor, besides going off of, well, if their A1C is 13, clearly there's an issue. But if it's 7 versus 8, that, I don't know, that's a big difference, you know, whether I can trust it or not.
Well, and I think you also look at your glucose levels that you get in your lab with your non-fasting values. You know, how bad are they? You know, if they're 110, are you going to worry about that? No. But, you know, if they're significantly higher when they come in and they're not fasting, then, you know, maybe depending on what it is, maybe you do want to send them home with a glucometer. You know, it turns out they give away glucometers like water. They make their money off of, you know, the test strips and so on. So, you know, most clinics have a bunch of glucometers lying around to give to patients, because really the big seller is the test strips. So, you know, that's certainly an option.
What about a lot of the monitoring and quality things, measures that include measuring hemoglobin A1C that we're held accountable to?
Yeah, Well, I totally get that. And honestly, I don't know how to get around it because the people who are measuring those quality measures, you know, you're going to have to do a lot of writing, a lot of letter writing to get around that. You know, it's a dilemma because, you know, you can write a form letter and every time it comes up and you get graded down because you're not doing hemoglobin A1Cs or whatever. It's not that you can't do hemoglobin A1Cs, but we're talking about diagnosis of diabetes. So those are different things. So, you know, it's not that you can't do a hemoglobin A1C, but, you know, if you're feeling like the hemoglobin A1C really isn't working out for a patient and you have to justify it, then, you know, I think you have to write a letter. But I still think hemoglobin A1C has value in people who are on antiretroviral therapy because often it will mirror to some extent how well their glucose is controlled. So I don't think it's useless, but we're really talking about diagnosis.
And Dr. Thompson, that was my question is how much can you depend on it for following the management of the diabetes?
Yeah, so I think, you know, you have to take it with a grain of salt, I think. So when you look at it at the hemoglobin A1C and, you know, it seems like it has changed a great deal. So, you know, let's say it was 7 and now it's 9. I think that's a conversation with the patient to see if it goes along with the other clinical characteristics. Have they gained weight? Have they stopped exercising? Or, you know, are they snacking at the refrigerator because they're locked down with COVID? You know, does it fit other clinical criteria? And, you know, again, I think we have mostly gotten away from being rigorous about people checking their glucose at home and so on, but there may be a setting in which if you feel that there's a potential that the person's really out of control, then you really get them to monitor their glucose for a period of time and send you the values. I do that a lot with my patients, actually. And for one thing, it also makes them aware of how whatever they eat affects their glucose. So,
there's a question in the chat room from B. Johnson. Do ARVs always overestimate A1C or underestimate, or is it random? I'm not sure if that was answered yet, but.
Yeah, both. They do both. And it's, I won't say it's entirely random, but I will say it's unpredictable for you as a clinician in the clinic. So, so it's a little bit of both. It'd be great if it were just one way. And keeping in mind, we use combinations of drugs. We're not using monotherapy to treat HIV. So, you know, we're using combinations of therapies, which may push the A1C in different directions.
And a follow-up question, but if ARV regimen is stable, is it fair to assume changes in A1C are reflective of changes in DM control?
I think it's better. I definitely think it's better. I don't think you could say entirely, but I do think it's better if they're on stable therapy, then I think it may be more reflective. But still, I think there's some wobble room. You know, this is an inexact science and we're really learning more about it, but, you know, clearly it's something that is not as much of, is not quite as reliable as we always thought it was in the setting of antiretroviral therapy. So there's a lot more to learn about this, but I think, you know, we need to always go back to the basics and say, what's the blood sugar doing? And, you know, if this appears to be a change in hemoglobin A1C, it's gone down and the patient says, oh yeah, I'm really exercising more, I'm watching my diet, then okay, this is good. So, you know, I think we still can use it, but I think it's important to be sure to take into account the antiretrovirals and the fact that they exist and whether they've changed.
Sorry, not to harp on this. Do you know anything about fructosamine in that case? If that's has any change, it might be a better monitoring tool, at least to get to goal.
I don't. I'm going to plead ignorance on that in terms of this context now. Okay, so let's go to another topic that I think we're actually getting pretty close to the end of our time here. But I am curious, there were a number of questions about aspirin, baby aspirin for primary prevention. And so I put together this slide just with some of the basics because I think this is another area where the answers are unsatisfactory. We just don't have enough hard and fast information about when to use aspirin in our populations living with HIV. So the US Preventive Services Task Force in 2016 basically said if you've got a 10-year risk greater than 10% and no bleeding risks, then go for it. If for patients over between 50 and 59, yes. When they get a little older, 60 to 69, reassess the risk benefit. They're more likely to have bleeding and less likely to have benefit. So, you know, the issue, of course, is that the trials that were analyzed were up to 2014. And then after that time period, some other trials have come about that have made us question the absolute value of low-dose aspirin for primary prevention because of the risk of side effects, but also because there has been a decrease in smoking in the population, use of statins have lowered cardiovascular events and so on, and this may change the balance a bit. So the ARRIVE study enrolled people who are 55 years old or more with moderate risk of about 17%. And in this study, which was a fairly large study, there was no effect on cardiovascular endpoints for aspirin compared to no aspirin. And there was, however, more bleeding with the aspirin group. So 1% versus 0.5% experienced bleeding events. Then if you look at the cardiovascular events and diabetes study, they enrolled people greater than or equal to 40 years old, and they did see a lower percent of vascular events in the aspirin group. But this was offset by an increased percentage of major bleeding events. So the conclusion was that there was no net benefit for aspirin in this population. And then there is the SPRI study of people who were 70 years old or older. They were in the United States and Australia. And this study was interesting. It showed no difference in the clinical endpoints of disability-free survival, sort of composite endpoint, cardiovascular deaths, hospitalizations, but they saw an increased all-cause mortality that was associated with cancer and also bleeding. So in this population, again, a recommendation not to use low-dose aspirin. So I think this is, these studies do sort of change our calculus about using low-dose aspirin. And what about people with HIV? It's really a similar question to the lipid question. So how much does having HIV really increase risk? How much can we put that into our risk factor calculation? And when do we use aspirin for primary prophylaxis? So I'd be interested to hear what you all are doing. Are you all using aspirin in your HIV patients, or any differently than in the general population, or?
I am not. I'm just not using it for primary prevention any longer.
Yeah, I am with you, Donna. I feel like, you know, there may be some situations, some studies have suggested that if the risk is greater than 20%, and the person has no other bleeding risks and they're not in the extreme elderly population, then you might consider it. But no, it's really muddied the water here for us, and the risks of bleeding are substantial. Plus the lack of efficacy in some of these studies. All right, so I just wanted to throw those out. I think we are actually at our time. Is that right, Dennis? Or do we have a timekeeper here?
Yes, we should end it right now because we're going overtime.
Oh, bad on me. It was all that standing and up and down at the beginning. But anyway, I just really want to thank you all for attending this breakout. I really enjoyed hearing what you all are doing. And although there are a lot of areas here where we don't have hard and fast answers, I hope I have piqued your interest to stay on top of these different topics. And hopefully next year we'll be able to say something more about several of them. So have a great day and a great rest of the conference. Thank you. Bye.